This non-promotional podcast series is organised and funded by UCB, intended for healthcare professionals in the UK and Ireland.
Welcome to the Let's Talk About Dravet Syndrome podcast series. I'm your host, Micheal Taylor. I'm a consultant paediatric neurologist in Leeds Children's Hospital. In this series, we'll share practical input from specialists and real-life stories from patients and their families. This is to bring you closer to this topic, raise awareness, and empower the medical community to work closely with patients and their families to improve outcomes and quality of life. If you've not done so, please hit the subscribe button so you don't miss another episode. And if you love this podcast series, please do me a favor, give us a rating or review on whatever platform you're listening to us on. The reason we need this is the more positive reviews or ratings we get on those platforms, the more this podcast will be shown to those who have never listened to us before. The aim is to improve the lives of people who have Dravet syndrome. The first episode, we're going to talk about the facts about Dravet syndrome. The epilepsies as a group are heterogeneous disorders across all ages where people have epileptic seizures, and they have a significant impact on neurodevelopment, quality of life, and mortality. They affect about 6 million people in Europe, but 65% are going to respond to their first drugs or enter spontaneous remission in their lifetime. The remaining 2 million, 1/3 could benefit from a well-conducted surgical evaluation. But the rare and complex epilepsies affect 5 in 10,000 people from the general population. Then we have to do a bit of definition of the developmental and epileptic encephalopathies, what we call the DEEs as epileptologists. These are a group of disorders that occur at critical periods of brain development. And the ictal, which is the seizure changes, and the interictal, so between seizure changes, result in behavioural, cognitive, and potentially motor regression or stagnation. It's often associated with really aggressive epilepsy and can be associated with early death. Dravet syndrome is one of those conditions and occurs in around 1 in 15,000 people. So a little bit about the history. It was first described by a French epileptologist called Charlotte Dravet and was originally called severe myoclonic epilepsy of infancy in 1978. It was renamed in 1989 to Dravet syndrome after Dr. Dravet and her constant pursuit of ensuring this condition was well described. It affects both sexes equally, and the early history of these children is often really unremarkable. They're a nice, happy, normal little baby. It normally presents in the first year of life, and the typical time period that we would think of as an epileptologist is that child who presents around 5 months, usually or around the time of their first vaccines. And the seizures, historically, we do think about being triggered by fever. Now, while we think about fever, actually, that's probably only true in somewhere between 55 and 75% of patients. So we do miss some of those patients if we follow our historical thought processes. And it's also really important to keep in mind, 3 in 100 patients with a Dravet diagnosis will never have had a seizure associated with fever. So we have to really keep an open mind about how these children present. Whilst we do think of the seizure onset being in the first year of life, work by epileptologists worldwide have allowed us to redefine the criteria, and we now recognise that actually onset can be as late as 19-20 months. Depending on the mutation and depending on how the child expresses that mutation, it could even be beyond 20 months. And it's also important to keep in mind that this can present as early as 6 weeks. It presents with lots of different types of seizures. The most common seizure that we think about is that old historical presentation of what we call a hemiclonic seizure. But that's actually only present in about 35% of patients when they first present. What's more common is the generalized tonic-clonic seizures, which present in around 50% of the patients. We do think about this as a prolonged seizure, presenting with what we call status epilepticus, so seizures over 30 minutes. But that's only true in about 35% of patients. So only a third of patients present with that classic long seizure. And it's important to keep in mind, 7% have never had status epilepticus. So we need to keep in mind that whilst we have our historical description of these children, many of them present in different ways. It's actually really important to keep a thought process about how long a seizure can be, because actually a quarter will present with their first seizure being under 5 minutes. As I said, the historical name for this condition was severe myoclonic epilepsy of infancy. The myoclonic seizures, which are small jerks, are usually seen by the age of 2. Over the past 2 decades, we've really been expanding our knowledge of that phenotypic spectrum. Whenever we are diagnosing, we have to think about, is the child presenting because of fever? Is that fever because of a vaccine? Warm ambient temperatures, such as warm water or warm weather, can also result in children presenting. Excitement and physical activity can increase a child's core body temperature and result in a presentation. And we know that patterns and flashing lights also act as triggers. So it's really important to think about those children and ensure that you've taken a very good history about how they present and watching for any triggers, not just the temperature being associated with vaccine or a mild illness, but the other things that child is doing the time the seizure onset occurs. The usual diagnostic criteria, as I said, references the first year of life, but we know that some children who have a mosaic mutation in SCM1A, which we will come to, actually can present well beyond 20 months of age. We then think about the imaging that we undertake on these children, but most people say 100% of children will have normal neuroimaging. I know from my practice that's probably not accurate. I know some studies would say about 90%. Those are often the children that catch you out as an epileptologist and may result in you putting them on the wrong medication, and we will come to that. The EEG in these children, usually within the first year, is normal, with the median age of change of EEG abnormalities being around 26 months. But it can be up to as late as 18 years. The diagnosis of Dravet syndrome is based on a complex series of clinical features. It's not a genetic diagnosis. But in 2001, researchers found that certain genes, and specifically the SCM1A gene, was highly associated with Dravet syndrome. And what we recognize is that 85% of Dravet syndrome occurs in children or adults who have a mutation in SCM1A. 90% of these children will have a mutation which arises what we call de novo. This is a really simple way of saying it's not been found in the parents, but about 5 to 10% are inherited from the parent. And that means that there is a 50% chance of passing on that mutation to other children. But we also need to keep the other genes in mind, because SCM1A, when it comes to Dravet syndrome, gets a lot of attention. So we have to think about GABRA1, GABRG2, SCM1B, which I have a few of, STXBP1, SCN2A, SCN8A. And there are some conditions that are very, very closely related or mimic Dravet syndrome, such as PCDH19 encephalopathy, where the seizures usually start slightly later, usually around 11 months of age. They tend to cluster with seizures at the time of temperature rather than having prolonged seizures. And they tend to be a lot more photosensitive. But just because a child doesn't have an SCM1A mutation doesn't mean that they shouldn't get a diagnosis of Dravet syndrome. And more importantly, it means that they should still get the same access to the drugs that are used to treat it. Diagnostics in Dravet is often intimidating because people are worried about giving the wrong diagnosis for such a severe and serious epilepsy. And it can be as late as adult life. Many clinicians maybe not having done genetic testing. I know that my colleagues in Scotland have diagnosed patients in their 60s. I've personally had patients come to me at 8, 9, with an SCM1A mutation that nobody's really made that call. Having spoke with Dravet UK, our wonderful UK-based charity, things aren't improving despite our ability to test. It often means that children are on the wrong anti-seizure medications. Sodium channel blockers are contraindicated in Dravet syndrome. They're contraindicated when you have a loss of function mutation in SCM1A. This can have an adverse impact on their development, on learning, and most importantly, on their seizure control. And this potentially could be deadly. So there is an onus on pediatric neurologists, pediatric epileptologists, pediatricians with an interest in epilepsy, and general pediatricians and developmental pediatricians to consider ensuring you're thinking about doing some genetic testing, whether that be panel or, if you don't have access to gene panels, specific genes. And with the advent of new next generation sequencing, we are picking up these mutations much earlier. But that can be tricky as well, because what happens when you pick up an SCM1A mutation in a 3-week-old who's having seizures? You have to then think about, how does the sodium channel function? That is a very, very different case. And more importantly, that tends to be a gain of function mutation. And actually, in those children, a sodium channel blocker will be really useful as treatment. What has helped has been some of the protein modeling and gene modeling, and that's been really beautifully produced by Professor Brunklaus and the team in Glasgow. And they're easily accessible to any pediatrician or pediatric neurologist. What's becoming more interesting is making these diagnoses as early as possible, because we're entering the potential phase of gene therapy and early gene therapy trials. And that's a very exciting phase with Dravet syndrome. But also, right now, outside of these very, very exciting trials, we've got drugs that are really useful. We've got protocols which vary country to country, and we'll talk about that throughout our series. But we have treatments that we recognize work. For example, sodium valproate is the first line, pretty much used ubiquitously throughout the world. Second line varies, but we also know, more importantly, what drugs we need to avoid, such as carbamazepine, oxcarbazepine, lamotrigine, and phenytoin. And I'm as guilty as anyone else of having started the sodium channel blockers in a child presenting with focal seizures. And it always breaks your heart that you've had them on the wrong drug whenever you get that mutation back, inevitably a couple of days after you've seen them in clinic for the 3rd time. So it really is important to ensure you take the history as robustly as possible and consider what drugs you're starting on. The benefit is that we can hopefully put the children on the right drugs, or make sure they're not on the wrong drugs, And that doesn't just benefit children, but my adult colleagues as well will advise that that has an input on their patients. Many years ago, focal seizure would have initially started on a sodium channel blocker. We don't know, but I do think it's one of those things we always have to think about. And it's why I have lots of great colleagues in the UK in adult practice who are really keen to explore developmental and epileptic encephalopathies and who are going back, looking at the early history, because many of these mutations would have been missed. And as I said, my colleagues in Scotland have picked patients up in their 60s. And more importantly, it doesn't mean that we don't treat them the same way. We can get them access to the drugs that will make a difference to their epilepsy. We also have to come to one of the toughest subjects to talk about as a neurologist, as an epileptologist, and that's SUDEP, sudden unexplained death in epilepsy. We know that it occurs in about 1 in 1,000 adults and 1 in 4,000 children with epilepsy. Children with Dravet syndrome have somewhere between 15 and 20 times a higher risk. Some people will quote that by the age of 20, 17% of patients with Dravet syndrome will pass away with SUDEP. But with appropriate treatment, we can minimize that risk. The early diagnosis allows us to know what we're dealing with. And it may be as a pediatrician or a pediatric neurologist or as a family member, you want to take that time to consider, are we going to make the diagnosis early or am I going to wait for the other features to evolve? Usually, the second or third type of seizure phenomenology will emerge within the second year. The developmental impact, however, may take slightly longer to emerge, and we will talk about development in the next episode. It's really important to consider gene testing early. It's better knowing than not knowing, because you can tell whether or not we're going to be on the right drugs or on drugs that potentially could cause harm, even if the final diagnosis is not Dravet and it's genetic epilepsy, febrile seizure plus. We know we can avoid the wrong drugs. A really great study from Sweden, from Janssen in 2024, showed that 67%, 2/3 of patients have been on the wrong type of medication or medication that potentially could cause harm. In the UK, we're in a really privileged position from our whole genome sequencing expert lab in Exeter, have introduced R14 testing, which is a rapid agnostic whole genome sequencing testing for epilepsy in the under ones. This means we can turn the results around within a 3 to 4 week period. The children have to meet criteria. It does require a careful selection of the right patients, but it means that we stand the greatest chance of making an impact on their developmental trajectories. The thresholds for testing are getting lower. Pediatric neurologists, pediatricians with an interest in epilepsy, and general pediatricians are making the call earlier to get the genetic testing. But it's what we do with that investigation in our hand that makes a difference. It's by empowering the families to question us as clinicians and ask, why aren't we putting that label on? It's the fear of being wrong. But fear shouldn't dictate how we investigate these children. And more importantly, fear shouldn't let us try and fail to give a diagnosis for 3-4 years. The worst case scenario is we give a diagnosis early and we are wrong and the child's much better than we ever anticipate. The alternative is that we deny a child access to life-saving drugs.
Well, that's it for this episode. If you love this episode, please share it with your appropriate colleagues. The only way this podcast is going to get out there is by you lovely people sharing it. So I would appreciate it if you could. And if you want to stay with me and learn a little bit more about Dravet syndrome, then please join me on the next episode. For now, I'll say goodbye and see you next time.